Good afternoon, everyone. Thank you for joining the medical grand round today. I'm Dr. Timothy Lee. We have quite a lot to cover today, so we better start on time. In the following around 45 minutes to 1 hour, and Dr. Fion Luk will first present a case and then talk about some diagnosis-related issues on bloodstream infections, and then I will cover the treatment part. So I will hand over the time to Dr. Luk first.
Okay, thank you. So let's start with a case scenario. Okay. So we have Mr. Chen, who is a 70-year-old man with background history of IgA nephropathy and stage renal failure on hemodialysis every Monday, Wednesday, and Friday, as he was with inadequate dialysis on peritoneal dialysis. He has history of right lower limb calcifilasis on sodium thiosulfate, also have HBV cirrhosis on enterocardia with known AF not for anticoagulation. He was admitted for generalized weakness, shortness of breath, and lower limb edema for 1 week. He has no fever, but occasionally chills at night for 1 to 2 days. There's no other infective symptoms. So on admission, he was afebrile, blood pressure 110/80, pulse 95 on 2 liters of oxygen. He was not septic looking and speak in full sentences. The chest was clear, Hassan duo no murmur. Abdomen was soft, the lower limb with edema, the right lower limb calcifilasis wound was healing with no discharge. He was on HD via the right internal jugular vein catheter, and that was not infective looking. So this is the admission blood. See the hemoglobin level more or less similar. White blood cell was raised to 11.6 with a neutrophilic predominant. Platelet count was normal. And he was on HD with creatinine level around 600 something similar. The potassium was 6.1. He has deranged liver function, but similar as baseline as he was having cirrhosis. So the CRP was raised to 55. VBG mildly metabolic acidosis. Chest X-ray was congested, and there is known AF. So given the lower limb edema, shortness of breath, and also chest X-ray with congested chest X-ray, the first impression was mild fluid overload. So the management was fluid restriction, and then we consult renal team for HD plan. There is raised white cell count and also CRP, so septic workup was ordered. However, the blood culture was ordered with fever greater than 38 degrees Celsius, then we do blood culture. The patient was not septic looking, so at the time, antibiotic was not given. So the scheduled HD was arranged the next day and aiming the ultrafiltration 1.5 to 2 liters. And the next day, there is a hypotension with SBP around 95. There is mild tachypnea, mild tachycardia, and still on 2 liters of oxygen. Patient was still not septic looking. At that time, blood culture was ordered, given there is some hypotension. And the gram stain came back to be gram-positive cocci in cluster. And later on, the DNA for Staphylococcus aureus was also detected. So this time, a patient was reviewed, and the impression was still in fluid overload. The blood culture report was read. However, it was considered as contamination at that moment, as the patient was still not septic looking and still afebrile, so that antibiotic was still not started at that time. So later on, further deterioration, there's a hypotension with SBP 90. There is a tachycardia raised to 120. Now the patient had fever, and at night it was assessed by houseman and started on tazocine. Blood culture was repeated, and now came back first and second set of blood culture with the gram stain also gram-positive cocci in cluster, and the PCR test is MRSA positive. And antibiotic was switched to vancomycin by that time, as vancomycin is still the first-line treatment for MRSA in blood bacteremia. So the routine culture also came back to be MRSA. So we also take blood from the catheter, and it also grow MRSA. And the wound swab from the lower limb, the calcifilatis wound is multiple bacterial species, non-dominating. So the source for the infection is likely from the catheter. The right side catheter was removed, and the left internal catheter was inserted for HD. So the lesson for us to learn is that it is not necessary to have a fever for blood culture, and there's actually no magic temperature threshold for blood culture. And we should never treat Staphylococcus aureus as a contaminant and ignore it. If we have doubt, we should repeat the blood culture. And we also repeat blood culture to rule out persistent bacteremia or to document any clearance. So we use the PCR test when we see gram-positive cocci in gram stain. And when we see Staphylococcus aureus PCR positive, we do need to think of the possibility for MRSA and any need for MRSA coverage. So we see the history of MRSA infection, and we also do MRSA screening to see any carriage of MRSA. So actually for that case, we should start taking blood culture earlier when patient with sepsis, hypotension, and also tachycardia. And when should we do the blood culture? It is when we think that there is a high likelihood of bacteremia. So if we see patient with signs and symptoms that presenting to us makes me think of sepsis, makes me think of endovascular infection, whether you think of IE or a patient with history of ICD, pacemaker, intravascular catheter infection, vascular graft infection, or septic thrombophlebitis, or a patient present to you with like back pain and fever, then you may think of vertebral osteomyelitis and cystitis. Or a patient presented with confusion, decreased GC or sepsis or a seizure, that makes you think of meningitis, epidural abscess, ventricular arterial shunt infection, or with joint pain, septic joint looking, septic arthritis, then you should actually consider blood culture earlier. So this slide showing the summary of what I've said. If you think of sepsis, infective endocarditis, you should do blood culture. And those syndromes that mentioned earlier, if with a high probability of bacteremia, then you take blood culture. For other symptoms, like if making you think of acute pyelonephritis, cholangitis, prostatic infection, severe chest infection, then you should do the blood culture as well, as the organism that grow may alter the antibiotic treatment. Bear in mind that fever is not a must in these two columns. However, if patient only presented with isolated fever, isolated raised white cell count, and not septic looking very well otherwise, then a blood culture may not be needed at that moment. So this study tells us that fever and raised white cell count cannot predict bacteremia, as shown here that elevated temperature do not accurately predict bacteremia, nor does the isolated leukocytosis. However, in this study, they said that the severity of chills and also patient presentation with systemic inflammatory response syndrome do predict the bacteremia. So source, as mentioned earlier, definition as two of the following with hypothermia or fever, tachycardia, tachypnea, or increased white cell count, or leukopenia, or with increased immature neutrophils, then you think of bacteremia and do the blood culture earlier. Otherwise, patient presents with old age, or you have suspicious of endocarditis or raised creatinine, also factors that makes you think of bacteremia. So this table showing that the severity of chills and the presence of chills can also positively related to bacteremia. So another study telling us that those with positive blood culture, some of them can have normal body temperature, and some of them can also have normal white cell count. So fever and white cell count may not predict bacteremia as well. In this study, 80 patients with positive blood culture shows bandemia. Bandemia meaning there is band cell inside the blood, which is some immature white blood cell. So if you see left shift of the white blood cell panel, do think of it is sepsis and think of bacteremia. So how do we increase the yield of blood culture? First of all, is the timing of blood culture. We take the blood culture at around the time of spike of fever. And do bear in mind that some elderly patients, they may not be able to mount the fever. However, they may have a more progressive course and with higher mortality. Another thing is the amount of the blood culture, the blood you take. It is suggested 20 to 30 ml of blood should be taken for each culture bottle, and the lower limit is 10 ml. And then it's the site of the blood culture to be taken. It is suggested to be taken from the antecubical veins or in upper extremities vessels. Those that take from the femoral vessels or take from skin that is affected by dermatological disease, they may mount a higher risk of contamination. And we do use skin antisepsis to prevent and to reduce contamination. We take at least 2 bottles, one for aerobic and one for anaerobic. And if we have a higher suspicion of bacteremia, we repeat 2 to 3 sets of culture. So this study telling us that we have higher yield of blood culture if we take the blood culture before we give antibiotics. However, we should bear in mind that we should not delay the antibiotic due to blood culture was not yet taken. So how we differentiate genuine bloodstream infection and contamination? For definition of contamination, it is greater or equal than one of the following organisms that are only found in one bottle of the series of blood culture. These organisms including coagulase negative staphylococci, micrococcus, alpha hemolytic ferritin script streptococci, propionibacterium, corynebacterium, and bacillus species. And we have doubt we should repeat blood culture if we see these organisms. However, if we see organisms like Staphylococcus aureus, Streptococcus pneumoniae, E. coli, Klebsiella pneumonia, and other Enterobacteriaceae, Pseudomonas pneumonia, Bacteroides, and Candida, if we see these organisms in blood culture, they are usually clinically significant, and we should not ignore this. So if we treat contaminated blood culture, they can give you unwanted outcomes, including that you may prolong patient stay, you may use of inappropriate antibiotics, you use unnecessary laboratory resources and increase the cost. So this table summarizes how we prevent blood culture contamination. As mentioned previously, we have skin disinfected and we disinfected the blood culture bottle. And the blood culture volume should be taken with appropriate amount. And some study proves that with the phlebotomy team, we can decrease blood culture contamination. Surveillance and feedback is also important to regulate the rate of blood culture contamination. So this study tells us how we differentiate whether coagulase negative staphylococci infections is with clinical significance or not. And they developed an algorithm saying that if there is more than one set of blood culture showing the same organism, we should consider it as significant. And if there's only one set of blood culture with CNS, however, there is raised white cell count, or there's leukopenia, or there's immature white blood cell, together with fever or hypothermia or hypotension, then see the clinical presentation of the patient, and we present with all these, then we think it is a significant infection. So in summary, if we have doubt, we repeat blood culture, we see the clinical evidence of infection, and also we see the immune status of patient. If patient is with immunocompromised status, then those skin flora with repeated culture, or if severe sepsis presentation, do think of it is a clinical significance culture result. So then I would like to talk about rapid diagnosis. Conventionally, we wait for the culture result, but it may take in days. But now with the advance of technology, we can actually have faster result to know the organism identification and also the antibiotic susceptibility. So this earlier result can help us to have a better patient management. And also this is where the antimicrobial stewardship can kick in. We can streamline our antibiotic use. So this study shows us that inappropriate treatment, meaning use of inappropriate antibiotic, can actually lead to a lower survival of the patient. And this is a Marino trial, a study on patients with ESBL organism. If you see ESBL organism in the blood culture report, it may issue as sensitive to tazocine and sensitive to carbapenem. However, this study tells us that using tazocine may actually result in an increased mortality compared with meropenem. So tazocine is actually not inferior to meropenem. And if we see ESBL organism in blood, we should actually give carbapenem, no matter it's sensitive to tazocine or not. If you only see sputum or urine with ESBL organism, you may also consider tazocine, but not in the case of blood culture bacteremia. So this slide is the overview of a rapid diagnosis. For the organism identification, currently we are using multi-TOF. We can also use the nucleic acid test, the PCR test, for the positive blood culture. And for antibiotic susceptibility testing, conventionally we use disc diffusion as shown in this photo, and the E-test as shown in this photo, and this phenotypic antibiotic susceptibility test. You can see how the organism grows with different concentration and different types of antibiotics. So with technology advance, we also have this accelerated pheno. It is an automatic machine that can give you earlier result of how is the susceptibility of the organism to different antibiotics. For genotypic antibiotic susceptibility test, it means that we detect the gene that is corresponding to different antibiotic resistance. So there is, in foreign country, they have the film array blood culture identification, and the latest one is BCID2. We do not have this in HA, and hopefully we will have this later. So multi-TOF conventionally, how we do it, when we take the blood culture, and then we will put it in the culture media and incubate it and wait to see if any colony forming. This takes 4 to 6 hours. And after we have the colony, we put it inside the multi-TOF machine, and the result will give you the microorganism identification, which takes total 24 to 30 hours. And now we can use the direct identification method. We will centrifuge the blood culture sample, and then we take the microorganism pellet, and then we process it. This takes around 20 to 30 minutes. And then we put the sample to the multi-TOF machine, and we can have earlier result in 30 to 40 minutes. So what is multi-TOF? It stands for Matrix Assistance Laser Desorption Ionization Time of Flight. It is actually a mass spectrometry tool that allows rapid and accurate identification of genus and species for a wide range of gram-negative and gram-positive bacteria, as soon as the organism comes positive in the culture, or as the solid media. So we detect a characteristic spectrum of each species, and then we matches it with the large database of the instrument. So this diagram shows that if we have the colony, then we put in laser and then ionize the colony, and then we will have a spectrum of the bacteria, and then we match this spectrum with the database. So we also have multiplex PCR, including gene expert Staphylococcus aureus and also MRSA. This one, we do have it in our lab. Film array, as mentioned earlier. So using all these PCR tests, the turnaround time is 1 hour. However, it is with a high financial cost, and it may need a laboratory manpower, and also it is having a limited pathogen panel. So conventionally, we take 22 hours to wait for the blood culture to be positive, and then we do the gram stain, and then we do the subculture in 16 to 18 hours. Then multi-TOF for identification, it takes quite a long time. And if we need to have the drug susceptibility test, it takes 16 to 24 hours. However, if we use the PCR test, the film array, we can shorten it to 1 hour after the blood culture turns positive. So this is the panel of the film array with gram-negative bacteria, gram-positive bacteria, and yeast group. It can also detect for genes, for antibiotic resistant genes, as shown here. The limitation is that those beyond this panel cannot be detected. So the gene expert MRSA and Staphylococcus aureus, we use this when we have blood culture positive with gram stain showing gram-positive cocci in cluster. We detect the specific genetic targets of the Staphylococcus, including the gene SPAR, MAC-A, SCC MAC-ORFX junction. With the combination of these results, we can identify Staphylococcus aureus plus or minus with methicillin resistance, and we can also identify non-aureus staphylococci. The time to result is 1 hour, which can greatly decrease the time, and we can optimize our antibiotic therapy. So back to our patient with the PCR test MRSA positive and the culture also show MRSA. We then in our lab do the e-test to test for the antibiotic susceptibility. We showed that the vancomycin was sensitive. However, the vancomycin MIC level is 2 meaning that theoretically we need a higher dose of vancomycin to kill the organism, but that might be harmful to our body with a higher risk of overdose of the vancomycin. So when vancomycin MIC greater than 1, we won't use vancomycin. And then we look for daptomycin. It is also sensitive with MIC 0.5. So that's why antibiotic was switched to daptomycin. And given the patient with repeated positive blood culture, we also do IP echo, and the echo showing there's no vegetation seen. For MRSA or MSSA infection, we do repeat the blood culture to document any clearance. And after 5 days of daptomycin, there's no growth. So then I'll briefly cover the workup of common bloodstream infection, Staphylococcus aureus, and gram-negative bacilli. For Staph aureus bacteremia, the mortality rate can be high, 20 to 40%, and higher with MRSA. We do need a careful history taking and PE to look for any potential portals of entry, including recent skin and soft tissue infection, presence of any indwelling prosthetic devices, any intravascular catheter, orthopedic hardware, or cardiac devices. We also look for murmur to rule any infective endocarditis, to look for any infective endocarditis. And the symptoms that reflect metastatic infections, which can happen in 30% of the cases, including bone and joint pain, that may give you a hint of vertebral osteomyelitis, discitis, epidural abscess, any prolonged fever that makes you think of endocarditis, abdominal pain, especially left upper quadrant pain that makes you think of splenic infection, costal vertebral angle tenderness that will make you think of renal infection and also psoas abscess. So it was suggested that all patients with Staph aureus should undergo echocardiogram. And if you have a high suspicious, even the transthoracic echocardiogram was negative, you should proceed with the transesophageal echocardiogram. So clinically, we actually see how significant it can be for infective endocarditis. If only one set blood culture was positive, but you do not have any other obvious sources, then you should do the echocardiogram earlier. If you have one set of blood culture positive and you have explainable sources, like you have a drip site infection and you have cellulitis, and after you remove the drip, or if you treat the cellulitis, there no more blood culture positive, then you may not need to think of echocardiogram. However, if you growing more than one set of blood culture, or there's no other obvious causes to explain the bacteremia, or a patient with pneumoma, cardiac implant, then you do think of echocardiogram earlier. So we repeat the blood culture every 24 to 48 hours to document any clearance. If there's no clearance, do think of the metastatic infection. And if you worry about metastatic infection, do imaging, CT or PET-CT, to look for any other seeding of the abscess or microabscesses. So when should we consider echo? It is when we think of endocarditis. So we look for modified Duke criteria, that is for the diagnosis of endocarditis. Apart from Staphylococcus aureus, if your blood culture grows further than Streptococcus bovis, hazard group or community-acquired enterococci in the absence of any primary focus, or you grow Coxiella burnetii, and with a new murmur, do think of doing the echocardiogram earlier. The minor criteria for Duke's criteria, including preceding heart condition, injection of drug use, fever, vascular phenomena with arterial emboli or gene radiation, immunologic phenomena, including Osler notes root spots. So if you have these signs presented, and if you think of endocarditis, do the echo earlier. Then I'll move on to the work for gram-negative bacillary bacteremia. Gram-negative bacillary sepsis can with shock and with a mortality rate 12 to 38%. And the mortality rate is higher if patient did not receive their antibiotic timely and they did not receive any appropriate antibiotic. And there is increasing incidence of multi-drug resistant gram-negative bacilli. So that's why the antibiotic resistant pattern is important. Usually, the gram-negative bacilli bacteremia are including in enteric rods. That we commonly see is E. coli, Klebsiella, Proteus, Salmonella, Pseudomonas. And if we have these organisms, we should do the urine culture and do imaging to rule out any infectious foci and to look for any infectious foci. So the common antibiotic resistance, including ESBL and also carbapenemase resistance. So this study showing that for resistant gram-negative bacilli, inappropriate initial antibiotic therapy will associate with increased mortality. If we see organism that is intermediate resistance to ertapenem, then we will run this test. This is a gene expert test for the carbapenemase resistance. It tests for the gene carbapenemase, KPC, NDM, VIM, also group, and also IMP. So if the organism should have these genes, we will give the antibiotic accordingly, and this will be later covered by Dr. Timothy Lee. If we do this test, the result can be available within 1 hour, and then we can switch our antibiotic timely. So then I'll pass on to Dr. Timothy Lee to talk about management of bacteremia.
Before I move on, I would like to clarify a little bit on the significance of some of the organisms on blood culture. So now you know that many organisms grown on blood culture actually are clinically significant and we should not regard it as contaminants. And just now, Dr. Luke mentioned one of the study quoting that viridans group streptococci can be regarded as one of the contaminants, probably because it is widely colonized on our body. But you probably also remember that viridans group streptococci is one of the typical organisms causing endocarditis according to the Duke's criteria. So in reality, when we see a patient with blood culture growing viridans group streptococci, we would not regard it as contamination, and instead we'll repeat it and try to look for any features of endocarditis, especially for patients with underlying valvular disease or other risk factors. Okay, now I will move on to the treatment part. So I will focus more on Staph aureus bloodstream infection, or in short, SAB, as this is what our case I'll talk about. And I will also cover a little bit on gram-negative bloodstream infection. So there are two key components regarding the management of SAB, source control and also antimicrobial therapy. In order to achieve adequate source control, of course, you need to first think about the appropriate investigation to identify any potential sources or complications. Once this is done, then what you are going to do is simple. You just drain any drainable collection or abscess and remove any infected foreign bodies, including catheters, devices, prostheses, whenever this is feasible. So this study showed that delay in source control is actually significantly associated with prolonged bacteremia. And this is more significant than the choice of anti-staphylococcal therapy, actually. And each extra day of bacteremia starting from day 3 will result in a 16% higher risk of death. And the prolonged bacteremia will also lead to a higher rate of metastatic complications and length of stay as well. So source control is important. And then we will need to think about antimicrobial therapy. So usually we start with empiric therapy before we know the sensitivity results. As a general rule, the empiric therapy should be something broad spectrum to cover whatever possibility. And for example, in the case of SAB, we need to think about MRSA, especially if the prevalence of MRSA is high in the locality or if the patient has other risk factor. However, once the sensitivity results are available, we should always de-escalate the antibiotics to give a more targeted, directed therapy. Simply the patient is improving on a particular treatment is not a reason to continue with an antibiotic that has a necessarily broad spectrum. Of course, we also need to think about the dose and duration as well as the route of administration when we think about the antimicrobial therapy treatment. There's one concept that you must make it clear is the spectrum of activity is not the same as efficacy. So a broad spectrum antibiotic is good in terms of giving a broader coverage of the organisms. However, when you are treating something that is drug sensitive, a broad spectrum antibiotic may not give you any extra benefit. And in fact, in the case of SAB, the broader spectrum vancomycin actually gives you a worse outcome compared with the narrower spectrum beta-lactam, as shown in this study. Another question that we need to answer is how long do we need to treat? But to answer this question, first of all, you need to differentiate between uncomplicated and complicated SAB. So uncomplicated SAB is Staph aureus bloodstream infection that fulfills all of the following, including you need to exclude infective endocarditis by echo. There must be absence of indwelling devices or prosthesis. The patient's fever must come down within 48 to 72 hours of effective antibiotics. There should be negative follow-up blood cultures after 2 to 4 days of treatment, and there is no evidence of metastatic infection on physical examination. As long as any of these is not fulfilled, then the SAB should be regarded as complicated SAB. And the duration of treatment would, of course, be different. For uncomplicated SAB, usually we treat for at least 14 days from the date of first negative blood culture. However, there are some studies showing that this may be potentially shorter in some selected low-risk case, which I will mention later. For complicated SAB, usually the antibiotic treatment will be at least 4 weeks. So this is a study, retrospective cohort study, comparing short course, which is 6 to 10 days, versus a prolonged course, which is 11 to 16 days of antibiotics for patients with MSSA bacteremia. And it showed that there is no significant difference in 90-day mortality or 90-day relapse of infection between the two groups. And you can see there is obvious difference in terms of the treatment duration. This may be applicable to selected low-risk cases, for example, patients with bloodstream infection secondary to phlebitis. However, this has to be considered case by case. In terms of the choice of agents, for MSSA, there are two major groups. One is the anti-staphylococcal penicillin, including cloxacillin, oxacillin, or nafcillin. In our hospital, where we only have cloxacillin, so this would be the only choice for this group. Another group of treatment would be cefazolin, which is a first-generation cephalosporin. For MRSA, bloodstream infection, the recommended treatment include vancomycin or daptomycin. So for MSSA bloodstream infection, there is no head-to-head comparison in prospective studies between cefazolin and anti-staphylococcal penicillin. However, accumulating retrospective data, including multiple meta-analysis, consistently show that these two groups of treatment have comparable efficacy, relapse rate, and also mortality. Some data even show lower mortality with cefazolin. However, that may be limited by the quality of evidence and some confounders. And also consistently shown in the study is that cefazolin is better tolerated with a lower discontinuation rate due to adverse events. However, there is some concern about inoculum effect for using cefazolin. This is one of the studies showing that comparing cefazolin and anti-staphylococcal penicillin, the mortality and relapse rate is similar. And however, there is a lower rate of nephrotoxicity associated with cefazolin. Just now I mentioned inoculum effect. So what exactly is this? It means there is a significant increase in minimum inhibitory concentration for the bacteria at a high inoculum compared with standard inoculum. So examples of infection with high inoculum include infective endocarditis, bone and joint infection, and some other deep-seated infection. However, this is only an in vitro phenomenon, and the clinical significance is uncertain. One study demonstrated that there is increased mortality when using cefazolin for strains having inoculum effect. However, there are some other studies that show similar efficacy, relapse rate, or mortality between anti-staphylococcal penicillin and cefazolin, regardless of inoculum effects. So this would be a summary slide for definitive treatment for MSSA bloodstream infection. So one thing that is important is that we need to make sure an adequate dose has been given to the patient to allow optimal efficacy. So the standard dose for cefazolin would be 2 grams every 8 hours for patients with normal renal function, while for cloxacillin, it would be 2 grams every 4 hours. We see from time to time that patients have been given cloxacillin correctly. However, the dose would be something like 500 milligram or 1 gram every 6 hours, which would be obviously inadequate. And for patients with renal impairment, you need a dose adjustment for cefazolin, but not for cloxacillin. So you need to give 2 grams every 4 hours, regardless of the renal function. And regarding the side effect profile, cloxacillin is associated with a much higher rate of phlebitis, which is also one of the reasons, major reasons for discontinuation of this treatment. While cefazolin is more friendly to the veins, so usually the patient can receive this treatment for a longer period. And as shown before, acute kidney injury or nephrotoxicity is higher for cloxacillin. And there are some other studies showing that elevated liver enzyme is seen more often when you use cloxacillin compared with cefazolin as well. For CNS penetration, cloxacillin is better than cefazolin. So if there is a CNS foci of infection, then we should use cloxacillin instead of cefazolin. Inoculum effect I've just mentioned, however, the clinical significance is uncertain. So in summary, cefazolin is better tolerated and has a more convenient dosing schedule. It has a similar efficacy except in CNS infection or sometimes infections with high inoculum. So there are some strategies to decrease this inoculum effect. First is to achieve optimal source control and optimize the dosing. And the second one is you may use cloxacillin as an upfront therapy. However, when with time, when the infection is more controlled, then you can change it to cefazolin for completion of treatment. So you can see that the first-line treatment for MSSA bloodstream infection would be a beta-lactam, no matter if it's a cephalosporin or penicillin group. However, sometimes we are unable to give penicillin or beta-lactam group of treatment because the patients have been labeled to have penicillin allergy. So this is a study showing that patients who are labeled to have penicillin allergy has higher mortality or when they have MSSA bacteremia, when they receive vancomycin instead of beta-lactams. And even for those who are labeled to have penicillin allergy, some of them receive beta-lactam, and this group of patients would have a better outcome compared with receiving vancomycin. And actually, beta-lactam receipt is the most strong factor for associated with better survival. And please remember that there is a very low cross-reactivity rate between penicillin and cephalosporins, even for first-generation cephalosporin. In the past, this has been quoted as something like 10%, but more recent data show that this cross-reactivity rate is actually less than 2%. So even if someone has a genuine penicillin allergy, it doesn't mean that they cannot receive cephalosporin. And also, there are some recent studies showing that dual allergy to both cefazolin and penicillin is something rare. And in this systematic review and meta-analysis, analyzing more than 6,000 patients, the frequency of dual allergy is actually only 0.7%. If you break down this group into those with confirmed and unconfirmed penicillin allergy, those with confirmed penicillin allergy, meaning having an allergy evaluation and skin test, has a relatively higher rate of cefazolin allergy as well, but the rate is only 3%. For those with unconfirmed penicillin allergy, the rate of having cefazolin allergy is actually only 0.6%, meaning that a majority of patients with labeled penicillin allergy can actually still receive cefazolin. And many different studies show that beta-lactam antibiotics has multidimensional benefits, especially for the treatment of Staph aureus infections. And this cannot be reflected by the MIC alone. So if you come across someone with reported penicillin allergy, you need to dig into details to see what the allergy manifestation is like. And for those mild cases and non-specific cases, you can actually proceed with another beta-lactam therapy as indicated. Even for more high-risk case, you can consider more detailed allergy evaluation, including skin testing or graded challenge before you really choose a non-beta-lactam antibiotic option. So for MRSA bloodstream infection, vancomycin is still the first-line treatment under most circumstances. And again, optimizing the dosage is important. For vancomycin, we usually measure the trough level. We aim a trough level of 15 to 20 milligram per liter. And usually we can give loading dose to allow the optimal trough level to be achieved faster. And daptomycin should be used when vancomycin is contraindicated, for example, patients with allergy, or when vancomycin is not efficacious, for example, patients with persistent bacteremia or have a higher vancomycin MIC more than 1. However, when you use daptomycin, you should first confirm that a bacteria is susceptible to daptomycin. Also, daptomycin is associated with myopathy, so you should regularly monitor the creatine kinase level. And also for patients with on statin, you may consider temporarily withhold the statin while on daptomycin. And daptomycin is inactivated by pulmonary surfactant, so it would not be useful for patients with MRSA pneumonia. So this is lab results showing that MRSA strain with vancomycin MIC of 2. Usually for such kind of MRSA, the microbiology lab would issue an additional comment at the bottom telling you that the vancomycin MIC is high, so the vancomycin efficacy may be lower and you should consider alternative antibiotic treatment. And also these two photos show that daptomycin non-susceptibility may develop rapidly. For example, in this case, you can see the daptomycin MIC increase from 0.5 initially, which is in the sensitive range, to MIC of 4, which becomes non-susceptible within only a week period. In this case, probably the reason is due to inadequate dosage. So when we use daptomycin, we usually choose a relatively higher dose at 8 to 10 milligram per kilogram every 24 hours for patients with normal renal function. Sometimes patients receiving vancomycin or daptomycin may still have persistent positive blood culture. And if the patients have positive blood culture beyond day 7 of effective therapy, we can regard it as a refractory MRSA bloodstream infection. Whenever we encounter these cases, there are some questions that we should answer. First, is there adequate source control? Second, is the dose of antibiotics adequate? And as mentioned earlier, vancomycin, we need to titrate the dose according to the trough level, while for daptomycin, we should give a relatively higher dose to increase the efficacy. If the patient is on adequate dose of vancomycin and still have refractory MRSA bloodstream infection, we can consider switching it to daptomycin. If the patient is already on daptomycin, then we can consider adding ceftaroline. So this is a study named CAMERA-2 study to compare combination therapy with beta-lactam in adding to vancomycin or daptomycin to see whether it gives superiority in the outcome. However, it is shown that adding a beta-lactam to either vancomycin or daptomycin actually does not improve patient outcome in patients with MRSA bacteremia, and instead it causes more acute kidney injury. However, most of these acute kidney injury are probably due to the co-administration of cloxacillin. They did a post-hoc analysis of acute kidney injury occurrence and showed that for patients receiving flucloxacillin or cloxacillin, more than 20% of them develop acute kidney injury, while for those on cefazolin, there's only 4% of AKI. Just now I mentioned that adding ceftaroline to daptomycin may be an option for patients with refractory MRSA bloodstream infection, and there are some case series and also another randomized control trial showing that adding ceftaroline to daptomycin may speed up the clearing of bacteremia. And also the RCT, although it is a small one, it showed that there is a mortality benefit with the combination therapy. There is actually in vitro synergy between daptomycin and beta-lactam, as the beta-lactam may lead to some change in the surface charge of the bacteria, lead to a more effective binding of daptomycin. So this may partly explain the benefits seen here. So there are some other antibiotics that have activity against MRSA, including ceftaroline and linezolid. So, however, both of these agents are not approved for the treatment of bloodstream infection. And in the case of linezolid, it is a bacteriostatic antibiotic. So at this moment, we cannot recommend these two antibiotics as a first-line treatment for MRSA bloodstream infection based on current evidence. However, for refractory cases or when other choices are not preferred, then these may be potential options to consider. So another question that we want to know is whether we need to use intravenous antibiotics throughout the treatment course for patients with SAB. Is oral switch an option? So actually, some people look at some low-risk cases of SAB and found that oral switch may be a possibility. In this study involving more than 100 patients, involving mostly catheter-related bacteremia or skin and soft tissue infection in origin, there is no significant difference in mortality or relapse rate between the oral switch group and the parenteral therapy group. And as you can expect, there is a significantly shorter hospital length of stay in the oral switch group. However, the decision for oral switch in this study is at the discretion of the treating physician. So there may be some potential confounding by indication, meaning that only the less severe cases are being switched to oral therapy. There is another review talking about the oral step-down therapy for patients with uncomplicated SAB. And these are what quote these from the literature. And there is so far little high-level evidence to inform decisions. And the use of oral antibiotics should be considered on a case-by-case basis. And it can be a reasonable alternative for treatment of selected patients with uncomplicated SAB, provided that first, the Staph aureus isolate should be susceptible to oral antibiotics. Second, the patient is properly educated on the importance of a strict adherence. And third, the patient should be able to come back for follow-up reliably. And regarding the choice of oral step-down or oral switch, so far the published data support the use of oral linezolid. Another reasonable option that may apply sometimes is the combination of fluoroquinolone plus rifampicin. So those are about uncomplicated SAB. What about more severe infections? In 2019, there are two studies published in the New England Journal of Medicine. One is regarding infective endocarditis, another is about bone and joint infections. For the infective endocarditis, the POET trial, it studied the oral switch for patients with endocarditis, and it is shown that oral switch after at least 10 days of intravenous antibiotics is not inferior to continued intravenous treatment. And in the study, there are 20% cases of Staph aureus infection. However, there was no MRSA case at all. And also regarding the oral switch, they use a dual therapy, including two agents belonging to different antibiotic class. So we need to bear this in mind. And for the bone and joint infection study, which is the OVIVA trial, it is shown that the oral antibiotic was non-inferior to intravenous therapy when used during the initial 6 weeks. And in this study, there are almost 40% cases that are caused by Staph aureus infection. However, Staph aureus bloodstream infection or infective endocarditis, either on presentation or within the previous month, was excluded. So this study probably didn't give us extra information regarding oral switch in patients with bone and joint infections together with bacteremia. However, there is another study, a relatively small study regarding patients with complicated SAB done in the Netherlands. In this study, they arranged echocardiogram and PET-CT for every patient with complicated SAB to exclude endovascular infection. And for those with negative echo and PET-CT, they will give initial 2 weeks of therapy as intravenous formulation, followed by oral switch to complete a total 4 to 6 weeks of treatment. And in the end, there are 61 patients had oral switch at a median of 16 days of intravenous therapy. And the majority of them received oral clindamycin. And it's shown that there is no significant difference in 3-month mortality. And amazingly, there's no relapse occurring in either group. And also the median treatment duration is the same for both groups. And not surprisingly, for the oral group, the length of stay is shorter. So it probably gives us some support for the oral switch of complicated SAB if adequate investigation is done to exclude some metastatic infections. So I will spend a few more minutes on the treatment of Enterobacteriaceae bloodstream infection. So for this kind of infection, mostly they are of urinary or biliary in origin. In general, they are less prone to complications compared with SAB, with the exception of infection caused by Klebsiella species. And sometimes we do encounter hypervirulent strains of Klebsiella causing a metastatic infection, especially liver abscess and endophthalmitis. So these you have to exclude when you see a case of Klebsiella bloodstream infection. So the current trend for management of Enterobacteriaceae BSI is to shorten the treatment duration and also early oral switch whenever feasible. So this is a study comparing a short course, which is 6 to 10 days, versus a prolonged course, which is 11 to 16 days of antibiotic therapy for patients with Enterobacteriaceae bacteremia. So the median treatment duration for the short course group will be 8 days, while for the prolonged course group will be 15 days. And again, there's no significant difference in terms of mortality, recurrent infection, or Clostridium difficile infection. There was a trend of lower emergence of multi-drug resistant gram-negative bacteria in the short course group, which is beneficial. Another study comparing 7 to 14 days of antibiotic therapy for patients with uncomplicated gram-negative bacteremia. And in this study, about 70% of the bloodstream infection is urinary in origin, and 90% of cases are caused by Enterobacteriaceae, like E. coli, Klebsiella, and Proteus. And the primary outcome is a 90 days composite of all-cause mortality, relapse, complications, and also readmission. And to be eligible for the study, the patients have to be remain afebrile and hemodynamically stable for at least 48 hours. So in this study, there is, again, non-inferiority regarding a short course, which is 7-day treatment compared with the 14-day antibiotic therapy. The only significant outcome is for the short course group, they have a faster return to baseline activity. And they had another subgroup analysis to see whether the source of the bacteremia, whether the empirical antibiotic is effective, and also whether the bloodstream infection is caused by drug-resistant organism. However, none of these is found to be associated with a significant difference in the outcome. And a more recent study using the CRP-guided treatment approach to see whether shortening of antibiotic can be effective. In this study, patients are divided into 3 groups. One is the standard fixed 14-day treatment group. One is a fixed 7-day treatment group. Another is the CRP-guided treatment group, which the patients will have their antibiotics discontinued once their CRP level decreased by 75% from the peak level, and the CRP has to be measured every 1 to 2 days. So in summary, the CRP-guided treatment group has shown non-inferiority compared with either the 7-day or 14-day treatment group. And in the CRP-guided group, the median treatment duration is also 7 days, showing that 7-day antibiotic treatment for uncomplicated gram-negative bacteremia may be effective. And what about oral switch? This study showed that patients with Enterobacteriaceae bacteremia can do oral switch with without increase in the mortality or recurrence of bacteremia. Again, the oral switch group would result in a shorter length of stay. And similar to other studies, most of these cases are due to E. coli or Klebsiella, and also the source of bacteremia is mostly urinary tract and GI tract. And this is how the study is conducted. The patients would have oral switch between day 2 to day 5 of their bacteremia. And the most commonly used oral agent is a fluoroquinolone group, including ciprofloxacin and levofloxacin. So some people would think, does beta-lactam give a similar result compared with fluoroquinolone when we do oral switch for patients with gram-negative bacteremia? So this study showed that there is no significant difference, again, in terms of mortality or recurrent bacteremia for patients switched to beta-lactam compared with switching to fluoroquinolone or Septrin. And in this study, the most popular oral option in the beta-lactam group would be augmentin and also cefpodoxim. Even for more complicated gram-negative bacteremia, oral switch may still be useful. For example, in this study involving patients with Klebsiella liver abscess, and more than 150 patients is randomized to receive either oral ciprofloxacin or intravenous ceftriaxone. And among these patients, about half of them have positive blood culture growing Klebsiella pneumoniae. And in the end, the rate of achieving clinical cure at week 12 is similar between both groups, and there is also similar rate of adverse events, as shown in this table. Again, the length of stay would be shorter in the oral switch group. Another common question that we are being asked is whether we need follow-up blood culture for patients with gram-negative bacteremia. So for Staph aureus, we recommend routine follow-up blood culture every 2 to 3 days to document the clearance. However, in the case of gram-negative bacteremia, this is probably not necessary. As shown in this study, follow-up blood culture added little value in the management of gram-negative bacteremia. And you need to do 17 follow-up blood culture for yielding one positive result. And it's only if the patient has persistent fever, then the chance of yielding a positive follow-up blood culture is higher. So these are some take-home messages. Timely diagnosis of bloodstream infection is very important. And remember that patients with bloodstream infection can present with non-specific signs and symptoms. So a temperature threshold is not should not be the only indication for ordering blood culture. Remember, you have to order appropriate investigations to identify complications and facilitate source control. And whenever there is a sensitivity results available, the escalation of antibiotics should be done. If you want to use alternative group of antibiotics other than beta-lactams, think twice, as there's ample evidence showing the benefit of beta-lactam treatment for bloodstream infections, regardless of for gram-positive or gram-negative organisms. And short-course antibiotics and oral switch are feasible in selected cases. So thank you very much. And if you have any questions, then please type in the chat box and we'll try to answer those. So one of you asked whether we need to take 2 sets of blood cultures from 2 different sites. That's a very good one. In the past, usually for when people recommend a repeating blood culture, for example, in the case of a suspected IE, usually they recommend taking multiple sets of blood cultures at multiple time points and at multiple body sites. However, more recent studies show that this may not be necessary, and actually the volume of the blood culture taken is probably more important. So if you want to order more than 1 set of blood culture, you can simply take from the same site with multiple sets of culture bottles to increase the yield. Another of you asked what is metastatic infection. So, that's just with the term we use for some disseminated infection. For patients with penicillin allergy, is it worth the risk to give penicillin? So as mentioned, many a time patients being labeled with penicillin allergy do not actually have genuine allergy. It has been consistently shown that, and in local and international studies, that more than 85% of these kind of penicillin allergy label is incorrect when you bother to do more detailed allergy evaluation. So simply having a label of penicillin allergy does not mean that the patient cannot receive penicillin. And also, as I've mentioned, cross-reactivity between penicillin and other beta-lactam antibiotics is low. So even if someone does have a genuine penicillin allergy, it does not mean that he or she cannot receive another beta-lactam antibiotic treatment. So far, beta-lactam antibiotic is still the first choice for many different kinds of infection, including bloodstream infection. So whenever you see someone have a penicillin allergy label, the first thing you should do is to clarify the so-called allergy history to see whether the patient is indeed at high risk. Of course, if the patient has confirmed high-risk allergy manifestation, for example, Stevens-Johnson syndrome, and then probably you cannot give penicillin or related drug again. But for many cases, those label allergies, some mild manifestations like rash or some non-specific symptoms only. The site and timing not matter for the blood culture taken compared with the volume. I would say the most important factor would be the volume taken. And for the site, as mentioned by Dr. Luk, that usually we will choose some sites that appear less likely contaminated. For example, we would prefer the upper limb compared with lower limbs. And for timing, you probably don't need to, if you want to do multiple blood culture, you can order all of those at one go instead of waiting for another 30 minutes or 1 hour for another set. So is there any other question? If not, then thank you very much, everyone. Have a nice evening.